welcome you to today's webinar titled Creating Agility and Flexibility in Medicine Procurement for Public Health in Africa. We have a great broadcast for you today, and we're just going to start off with a few announcements. So first, this session is being recorded and we'll be making the link available to you on our website. Next, we would love to hear from you and we welcome your questions at any time. There's a little questions box on the right-hand side of your control panel, and you can type in your questions at absolutely any time, and we'll read them aloud later when we pause for questions from the audience. These web conferencing platforms, as you know, are experiencing a high volume of traffic, so we just ask for your patience in advance if we encounter any technical difficulties with the audio or video. We just ask that you hang with us and we'll get it fixed as quickly as we can. And finally, we ask that if you're not speaking, if you could please mute your line so that you're keeping the line nice and quiet for others while they're talking. And that now concludes the little announcements portion to kick off our webinar. So it's my absolute pleasure to hand it over to my colleague, Per Kronslev, a senior supply chain consultant for i+solutions. Per?
Thank you. My name is Per Kronslev. I work with i+solutions as a senior supply chain consultant. We have on the webinar today, I think you should change the slide, right? Yes. So on the webinar today, we would like to discuss how the procurement is going to work out for donor-funded public health products. We do know there's a consensus that we got well-functioning, large-scale donor-funded procurement happening with these various institutions, such as the Global Health Supply Chain, PSM, the PPM for Global Fund, this kind of mechanisms. They're there, they work, but this very concentrated procurement is not that well linked to what's happening in the countries, and there's sort of a disconnect often. And we need things to move in that sense. And this is what we'd like to talk about here. How can we move from where we are now in terms of the procurement of these products? Yes, we have some participants. I think they're on the next slide. Sorry, we have two statements. Yes, those are we have two statements we'd like to debate. One is that we think value for money and efficiency can be achieved with a central global agency negotiating framework contracts, and that we think that actually is a truth. But there's also another statement we'd like to debate, which is that this large-scale manufacturing to order, shipping in large volumes, this creates challenges for the countries. It creates, you need large volume storage, long forecasting ahead in an environment with limited data, and with the difficulty to actually deal with this kind of volumes, where you would prefer a more flexible procurement. So these are two statements we would like to debate with these participants. And the participants are, we have Joe Kalani. He's the director of pharmaceutical operations at CMST in Malawi. This is a central medical store. We got Prashant Shah. He's the CEO of the Pharmaceutical and Chemical Distributors in Zimbabwe. This is a private owned wholesaler in Zimbabwe. Then we should have Emeric also. He might have some difficulties. Emeric works as the head of institutional clients at Eurapharma. They own a large pharmaceutical chain called Laborex in West Africa, mostly West Africa, but also other parts of Africa. We have Wesley Kreft. He's the director of supply chain, managing the PPN for the Global Fund, for most of the PPN for the Global Fund. Yeah. So I think that's about it. Now we will do some statements by each of the participants, and after that, I'll ask some questions. We'll have some talk about it, about the subject. So the first we would like to ask is from the Central Medical Store, Joe Kalani. So can you take over?
Thank you so much. I think from my side, giving taking reference to the scenario in Malawi, is that we're saying the supply chain, the pharmaceutical supply chain in Malawi remains very disintegrated, with so many players participating in the supply chain. With regard to the title, in terms of
Joe, I'm sorry, we've lost audio for you. It seems that your microphone has been disconnected. Joe, can you hear us? I'm sorry, folks. It looks like we're having some audio difficulties with Joe. He's speaking, but we don't have the audio connected at this moment. Per, I think we should go over to the next speaker, and I can help Joe troubleshoot his audio, if that would be okay.
Okay, that's okay.
Thanks.
So I think we'll take the next speaker, and then we'll get back to Joe. Okay, Prashant, Zimbabwe, can you take over now?
Thanks. Yeah, thank you, Pierre, and good afternoon to all of you. So, Pharmaceutical Chemical Distributors was established in 1993. We import and distribute generic and branded pharmaceuticals for both the public and private sectors. We have 47 credible generic and innovator manufacturers and 6 local manufacturers that we deal with in Zimbabwe. And our customer counts is over 2,000, of which 400 are in the public sector domain that procure directly from us. We have 15,000 square meters on the roof, split over 2 sites, one each in Harare and Bulawayo. These are all MCAZ and innovator approved sites. So we've gone through the whole QA process, and we're always upgrading ourselves in that. So PCD is well versed in with local public procurement regulations, which are managed by NatFarm, which is the state-owned entity. NatFarm initiate tenders for supply ultimately destined for the public sector, or the request for quotations are raised by the institutions for immediate supply, where there is no stock at NatFarm, which is currently the case. Of course, there's challenges with the way the procurement processes work. It's well known in Africa that there's a lack of data, both at central and user level. So there's poor allocation of resource for the end user. There's insufficient foreign exchange that's been allocated to the health sector in Zimbabwe, and the health sector is heavily dependent on donor funding, especially for the drugs that Pierre has mentioned, the HIV, the anti-TB, malarial stuff. The local manufacturing is constrained, variety of reasons, lack of resources, dated product profile, old plant, etc. Then there's obviously the abuse of funds. It's in the public domain, where funds for COVID were abused twice, 2 occasions, and the second one most recently last week. And then the shrinkage, where stock goes for a walkabout and doesn't get to the intended recipients. So what can we do to improve this, and what can PCD do? So we deal with multinational donors anyway. We deal with Chemonics in Zimbabwe. We have approved locations. We have approved warehousing in the 2 locations and access to additional warehousing facilities with all the bells and whistles that go with it. As we deal with the 400 odd public institution suppliers, of course, we have the logistical support to do the last mile delivery to these institutions. And we can assist in establishing reporting solutions to correctly manage stock levels of the public institutions and build a credible database on drug consumption in the public sector. We do this anyway for the private sector. So it'll just be a case of ramping it up for the public sector. Yeah, I think that's about it, Pierre. Hello?
Thank you very much.
Yeah.
Prashant. So I think we should go back to Joe. I think you got your audio up and working now. Are you there? Are you ready, Joe?
I hope
Okay.
so. Can you hear me?
We hear you clearly. Okay, so
Okay.
it's yours, Joe.
Thanks so much. Just to give a little statement on the topic under discussion. In Malawi, the supply chain, especially the pharmaceutical supply chain, is very disintegrated. Very disintegrated in the sense that there are so many players doing different aspects, operations within the supply chain. So in relation to the topic that we're talking about today, I believe that to achieve agility and flexibility, the supply chains must be managed totally, both upstream as well as downstream, as well as across internal and external relationships. And that can only be achieved through collaboration and cooperation. We believe that collaboration works if there is trust among the partners involved. And to be truly agile, there has to be collaboration. There is always need. There is need for information technology so that the partners should be able to share data, should be able to collect and align their processes so that they manage the next ways to make the best use of their respective strengths and competences. Accurate data is very critical if we are to come up with accurate quantification as well as forecasting. And all these are very critical if we are to avoid stockouts as well as expiries, which result due to inaccurate data used in those processes. Being flexible, we see that supply chain partners should be market sensitive and client sensitive. In this case, we are looking at the supply chains should be focusing on the patients that they serve and to meet the patient's demand at the facilities. So both procurement mechanisms, healthcare system should be able to change and react rapidly to satisfy patients' demand. And one critical aspect in this, especially in the African setup, is that the partners should share and invest in human resources for skill and the knowledge transfer for them to be able to operate efficiently. And for the sake of Malawi, we are in the process of implementing a supply chain transformation project, whose aim is actually to bring all the parallel supply chains into the national system, and that is the one that is managed by the Central Medical Stores Trust. All this is actually aimed at achieving efficiency and eliminate duplication, which end up wasting the very scarce as well as limited resources. Thank you so much.
Thank you very much. Sorry. Yes, thank you very much. The next one we should put on is Eurapharma. I don't know if he managed to get Emeric on board. Is he on the? Are you on right now?
I have him here, and Emeric, I am unmuting you. So if you can unmute yourself, you should be able to speak.
Yeah, I'm able to do so. Sorry again, for some reason I couldn't connect. I tried a bunch of times, but it seems to be working now. So we're just getting to my part, is that correct?
Yes.
That's correct.
So again, all apologies, but as we all know, technology has its failings. So as regards the way Eurapharma can help improve procurement of essential drugs in Africa, I think it's pretty straightforward. It's based on our current capabilities. So we've got a presence, we've got subsidiaries in 14 African countries as a wholesaler and distributor of pharmaceuticals. So one obvious way we could help is to hold inventory of essential drugs in these locations and basically plug them into our distribution network and capabilities. We currently mainly distribute to pharmacies, drugstores, but there's no reason why we couldn't do the same thing for clinics, hospitals, etc. So that's one way. Our existing warehousing and distribution capabilities in 14 African countries. Another way is that we do a lot of procurement. We have about 400 labs or manufacturers that we get our drugs from. So we have expertise in this area as well. And through our subsidiary Mission Pharma, we've got a special focus on procuring quality assured generic medicine. So when you combine the two, let's say the logistical capabilities and the procurement expertise, we should be able to, at our measure, help improving the procurement of essential drugs in Africa. This said, like I'm mentioning in my slide, that warehousing space comes at a premium. Obviously, if we were to hold permanent inventory of essential drugs subject to call-offs by clients, then we would need to make sure that this makes sense financially, because the flip side would be that we would have less space to stock our usual range of medicines. So basically, that's it in a nutshell.
Thank you very much, Henrik. So that was Henrik, Eurapharma. Now, the last one would be Wesley Kreft, managing the PPM procurement.
Yeah, good morning, good afternoon. I hope you can hear me well. Let me just continue. So I'm speaking here on behalf of i+solutions. We are one of the largest public health procurement service agents, supporting over 65 countries with procurement and logistics of health commodities. Predominantly, we do that as the procurement service agent for the Global Fund and the by Global Fund funded food procurement mechanism. And more and more, we are involved in the questions around transition and what that entails for individual countries. In our view, it has several elements. So we like to say that the roadmap to self-reliance is actually an opportunity for countries to make a choice, and there's no good or bad in that decision. So on one hand, there's a very valid reason to say there should indeed be an investment in additional funding, additional turn on my there's an investment in you also referred to, and how best to mobilize that. The other option is the option of outsourcing. So even in highly well-functioning commercial sector supply chains, the element of outsourcing is often used. And the reason why outsourcing is used is it's simply not always the right decision to have the technical knowledge on all different elements. And in our view, procurement and supply chain management is a typical example of activities within that you can easily outsource. So you can, for example, decide to outsource your sourcing and due diligence of suppliers. That saves a lot of capital not doing audits or not going and meeting all these suppliers at their premises. The other thing is obviously quality assurance. Quality assurance is a very laborious process, especially if you have to do GMP audits with suppliers. So that's a great opportunity to outsource to professionalized or to coordinated organizations that do that on a day-to-day manner. Another option is through these donor programs, a lot of gains were made by establishing long-term agreements that covers multiple countries. And a comment we often hear is when a country transitions and start managing their own procurement, they are being confronted with much higher prices. So there are multiple mechanisms out there where individual countries can still benefit from the negotiated global prices and ask an outsource agency to actually establish long-term agreements and bundle that with the procurement done for multiple countries. And then there are some other elements like the management of suppliers, order placement. But I think the main topic I want to bring in here is it's a country choice in the roadmap to self-reliance to decide which elements you rather do within a government-owned organization or within the private sector in your own country, and which elements you prefer to continue as an outsourced service. So with that, back to you, Pat.
Thank you, Wesley. So now I will ask some questions, but if the participants feel like themselves just going into the talk, then I think they should do so. Well, the first question I have is, and I'll be focusing on procurement here. There are many interesting elements, but let's try to do mostly procurement. Now, for a long time, it's been talked that we would like the private sector in these countries to be part of this type of work, but it has by and large not materialized. So right now here we're having Eurapharma, we got PCD from Zimbabwe. These are true private sector operations in Africa. I'd like to ask if we could start with Eurapharma, the Laborex chain, Emeric. So would you possibly be willing to do this work based on, for instance, on framework contracts made by other people? They could be made by the Global Fund, for instance. But then it would be your operation in a country, could be Mali, who actually did the procurement and managed things. Would this be an option for you? And if it is, what would it actually take to, I mean, what would you require to be interested? Because we do know also that you have limited time and resources and so on, and it has to be possible for you. If it's too difficult, you probably won't go there. But could you say something about, would you be interested in this kind of work?
Sure.
Mike?
Yeah, just to be a little more specific as to why I have to stress the financial component. It's not that we're overly greedy. I mean, we're normally greedy as a private operator, but we do have capacity constraints. You just took Mali as an example. We're building a new warehouse because we're exceeding capacity, right? So just to make it clear, it's not just because we're looking to maximize profit on every operation. We have to make choices. As to whether the country subsidiaries would be able to do the procurement directly, they would, and it would be simple in the sense that all our procurement is actually centralized in Paris, not in Paris, in France. We've got a logistical and procurement platform in a port city called Rouen in France, and all the procurement is done there, and they're responsible for dispatching the orders to each country. So it would basically just be the same system with the existing centralized platform, and Mali would just have to, well, basically in the system, place orders for these new drugs that we're talking about. So it's very feasible. It's just a question of creating new SKUs in the system. As to whether we would be willing, we would. I mean, our general mission, first of all, is to provide African nations with quality drugs and pharmaceuticals. So that obviously is totally aligned with what you're talking about. But again, it would have to make sense from, let's say, an arbitrage perspective, to allocate resources and warehouse space to that. We're also very cautious when it comes to the expiry risk of drugs. We obviously try to minimize the wastage there. So our preferred solution, the ideal solution, would be for us not to be the owner of the inventory, but just to provide the logistical services in terms of procurement, warehousing, and subsequent distribution.
Okay, thank you very much. And I would actually like to ask the very same question to PCD, to you, Prashant. I mean, what would you require if you were going to be part of supplying these products? What would it demand to make you interested in bidding on this kind of work?
Yeah, thanks, Pierre. I think my colleague earlier kind of covered most of the points. The issue here is really as onto who takes ownership of the drugs, and should there be any shortfalls, expiry, etc., who is responsible for those. Zimbabwe is slightly different, perhaps from the rest of Africa in terms of its local requirements, but we can certainly manage that locally. Like I said earlier, we deal with the public institutions anyway, so it's not a problem so much as in doing the last mile delivery and managing the stock for them or whatever it is. It's really just the aspects surrounding the procurement, who does the procurement, how do the bills get settled, and who takes ownership of shrinkages and shortfalls. That would have to be, thrashed out in any contract or discussion that comes out. And Zimbabwe, as you know, I mean, there's a huge payment issue here, so that would also be a problem for us. That's about, yeah, that's it. Thanks.
Okay, thank you, Prashant. Yeah, so there seems to be some possibilities there. Now, I'd like to ask you, Joe, from the CMST. So, as you say, rightfully, that it's very important to get collaboration with these supply chains. But do you see a way where you might be able to get flexibility, collaboration through working with, I mean, you're in Malawi, obviously, and the other people in Zimbabwe and in West Africa mostly, so it's different places. But do you see ways where you could, with the central medical store, the public central medical store, work together with private wholesalers to create flexibility to make this happen? You have a comment for that, Joe?
Yes, there is that potential that as a trust we can still work with the private sector, the wholesalers, to create that, because I think the major issue that hinders in terms of flexibility is in our case, being a public entity, using the public procurement methods, there are certain things that you need to adhere to. So bringing involvement of the private sector obviously allows us to overcome some of the challenges that are met with the current setup. We are already working with the private, but in different aspects, not necessarily in procurement, But we are currently doing outsourcing for the distribution, the last mile distribution. So that is part already with working with the private, and we've seen that there is flexibility in that way, because in terms of how they source the trucks, how they do that, they don't have to go through the lengthy procurement process in identifying the partner. So there is that potential. Thank you.
Okay, so yeah, so you actually have you are practically outsourcing the transportation. Did you say also something about the procurement methods that you would like them to be changed? Is this question of your public rules, or how would you like it to be changed if you should work more with the private sector? That's also for you, Joe, again.
Yeah, on that one, what we see is there are certain requirements for the public procurement entity. For example, if you are to advertise for an international competitive bidding, then you are supposed to advertise for a certain period. Normally, in our case, it's about 42 days. Now, if they are to do that advert and then you follow all the procedures to get the approvals, you find that the procurement process itself, the procurement lead time is much, much longer. And that has good consequences when it comes to inventory management, because it means you have to keep a little bit more to be able to avert any potential stockouts. A thing that in the private, it is slightly different, because they have a different mechanism in terms of the way they do their procurement.
Yes, so they can react faster. Okay, so I would like to get back to Wesley Kraft. So maybe you could say something about how these possible, I think you mentioned something about framework contracts. If they are made outside, maybe not in country, maybe they're made by one of the large agencies or whoever, but how they could be used by a private wholesaler or by a central medical store. Maybe you could say something more about that, how this could link together practically. I don't think it exists so much yet today, but maybe you could say something about that.
Yeah, and maybe I can use the example which is used a lot, for example, in the United States, and it's the so-called group purchasing organizations. So what that mechanism is, there's a collective understanding that purchasing is often a volume business. So the more volume you have to bring to the suppliers, the more gains you will get, either in terms of better pricing, better service, and more attractive lead times. So by using that mechanism and continuing to build on, I think, some of the good practices that the donor community have established through this coordinated buying, you can continue that effort, because if we just take, for example, the HIV patients, we all know that if we want to reach the WHO and the Sustainable Development Goals, there's going to be at least 30 to 40% more patients being put on treatment in the next couple of years. There are pretty attractive prices negotiated now. The suppliers are offering these prices because there is a guarantee on the payment, there's a reliability on the supply, and there's consensus on the volumes that will go through these suppliers on an annual basis. All these things you can achieve by putting together either global or regional long-term agreements, but it would still be possible for individual countries, different from the mechanism that's being used now by the donors, where it's often a procurement agency. I think it's still possible for individual countries to place their call-off orders under these long-term agreements. There's a requirement of data share. There's a need for some level of predictability, but I don't think it requires the heavy investments in forecasting and quantification. Because if we take Malawi, for example, I think it's for and some of the other larger diseases, it's very predictable on the amount of patients that will be there today and that will be there in the next couple of years. So with that volume, we can already, or an organization can already negotiate very good terms with the suppliers, upon which the individual countries can decide when to issue the purchase order and when to release and want to have the delivery of the actual consignments and the orders. So I think that is just an example on how it works. It's being done in many industries, as I mentioned. So I'm a firm believer that with the transition and the move towards self-reliance, yeah, this model can easily be implemented in many of the countries we are currently supplying for under the donor programs.
Okay, thank you. Yes, so that should be possible, but there is some challenges here, which I guess they also exist today, and they would also be in that environment. This is a challenge of volume. I think Emeric, he mentioned it. I am sure it will also be the case for Prashant. I think it's actually also in the Central Medical Store of Malawi, even though I think they got some bigger warehouses recently. But this volume issue is there, where you're having, if you buy very large volumes, you ship very large volumes at a time, you get a good price, obviously, but there's a lot of practicalities around this in the countries. So a question could be to how to practically be able to deal with this. I mean, could it be possible that some of the products are being delivered based on private wholesale who has it physically ready, available there, while others are coming in, you could say maybe the bulk are coming in via large volume contracts, but that doesn't cover all of it. The top of it, the fluctuations, the things you can't predict really, could be covered by private wholesale. And that way could be a way to get flexibility. Or is it possible to simply make it much more flexible, the deliveries into the countries? Because this is kind of a, at least I've understood from at least everybody, also both private wholesale and the medical stores, this is a challenge, this.
Yeah, so maybe I can give a first short answer, and then I think it's very good to hear from the countries themselves. But I think there are two options. There's currently supply chains are managed in silos of donor programs and silos of commodity groups. I think there's a great opportunity that if you break these silos, that actually in a country like India, where the majority of the pharmaceuticals are being produced, a container is filled and consolidated with products for a malaria program, an NCD program, an HIV program. So you're actually not shipping a full container of HIV medicines. You're actually shipping a full container of combined drugs that are needed for a given period. So I think that's one opportunity. The other opportunity is indeed, and that can go next to what I just mentioned, is to actually use the local private sector, wholesalers and distributors as an entry point into the country and ship certain products to the private sector entities, and they will coordinate on the onwards distribution into the country and coordinate with the different programs that exist within the Ministry of Health and potentially the central medical store that will continue to manage some of the supplies. So I think there are two options that are definitely possible also in the transition. Maybe over back to the other panelists there.
Yes. So Joe or maybe Emeric or Prashant, do you have a comment to this issue of how to get flexibility in there and not have to deal with full container loads of one product?
Hi, Per. Yeah, so that's what currently happens in Zimbabwe, is that when NatFarm run out of stock, they would issue the RFQs, the direct RFQs, and then they would pick up stock from us. They would ask us to bid for a price, for a product, give them a price, and go to other distributors within Zimbabwe stating the quantities available for X stock delivery. And if you're successful, obviously you get the order. The challenge is that, of course, the pricing is totally different compared to what you would get pricing at a global level, because the products that were destined for the private sector. So it's not public sector pricing for ARVs, for example, that the global fund would have received. So that's where the challenges come. But yeah, I think filtering products through the private sector, ultimately destined for the public sector, works anyway. We do that here in Zimbabwe anyway. So for Zimbabwe, it wouldn't really be much of an issue. It's just a question of making sure that the pricing is then transparent and in line with what is out there for all stakeholders.
Yeah.
Yeah. Okay.
So
right. Just
Sorry.
one comment from my side. I mean, container size is less of a problem for us because, like I said, we've got this logistical platform in France where we consolidate the orders going to a specific country. And so we could fill the containers partly with those orders and partly with our regular orders. So it's less of a problem for us.
Sure. That yes. Thank you, Emeric. Yeah, so you're having a practical solution there. But Prashant, you mentioned this thing about the pricing. That's of course a very important subject. I'm not thinking you necessarily have some easy solutions to this, but have you any ideas to how I mean, given you work with this kind of product we're talking here, it would be a case where you are having a secure payment. That's one thing. You don't have a risk on the payment because the money will be there. But can you think of a way to bring down these prices? But of course, you still have to live and maintain your business and your people and those things. So can you think of a way to do that so that you avoid risks yourself and therefore can bring down your price to a reasonable level?
Yeah. Yes. So what can happen is that if like what was earlier, I think Wesley stated, if the silos are broken down, so everyone knows what the other guys are doing, so there's no duplication of product, one, which leads to expiries. But all we would want is to have access to the same manufacturer. We have access to the same manufacturer that Global Fund has. We would just want to be totally transparent on the pricing with them to say, well, if this is destined for Global Fund customers in Zimbabwe, this is the pricing that we should want. We would want Global Fund to set the price. And as far as we're concerned, it'll just be a log fee, a logistical fee for managing the inventory and doing the ultimate distribution out. So it'll be their stock in our warehouse, which we're managing for distribution for them. If the challenge here comes is that if I was to buy an ARV for the private sector, Cipla would charge me a totally different price compared to what Global Fund would get for the same product, because the volumes are just not there. And this is where the challenge comes.
Of course.
Yeah.
So that, I think that sounds quite interesting, actually. So there could easily be some possibilities, given your risks are taken away. And I think, Emeric, you also see this possibility of having a, for lack of a better word, transparency, so that you don't risk the expiries. I mean, if you have a knowledge of what's in the country and what's going where, so that you don't risk to put a lot in stock, which will expire in your hands, that would be able to make you bring down your prices.
Probably. At the same time, the situation is different in French-speaking African countries than it is in English-speaking African countries. I don't know whether exceptions can be made for certain programs managed by the Global Fund, etc. But in French-speaking African countries, the prices for drugs are set by law, and they're the same for every wholesaler and distributor. So again, provided that we don't get an exemption from that rule, there's little we can do in terms of how cheap or how expensive the drugs can be. This doesn't apply to English-speaking Africa, but for French-speaking Africa, it's a major consideration. Another major consideration is the need to register those drugs. So that's true for every country in Africa, but the actual length of the process varies tremendously from one country to another. And one other consideration is that, like I said, all prices in French-speaking countries are set by law, but by law also all wholesalers need to distribute the same range of products. So if, again, we don't get an exemption for that program, there's the fact to take into account that other wholesalers could have, let's say, the right to provide the same services. Whether it would make it less or more attractive to us, I can't say at this stage. Could make it more attractive in the sense that we would need to utilize less of our warehousing space, for instance. But then it would probably require from the reverse side to get all wholesalers on board there.
So it sounds well, getting all wholesalers in a country on board sounds challenging in terms of agreements and stuff. But what really comes out is also there seems to be, if one wants to go down this route, it's important there'll be a design difference between Francophone and Anglophone Africa. It sounds like that. It sounds like that one really must think that there's absolutely not a one size that fits all there. There's a big difference.
Yeah, that's absolutely true. Again, maybe exemptions can be made for certain campaigns, certain drugs, certain programs, etc. But the principle is the one I just described, meaning all wholesalers provide the same services at the same price under the same conditions.
Yes. Okay. So that's but that's some interesting thinking, and it sounds like there's at least there's some opportunities. Now, okay, let's look at the time. I think we still have some time.
Maybe Per, I can make one more comments, and just as an example, one on what Prashant just mentioned. I think it's changing. We see more and more that actually the ARV suppliers, particularly, they refer private sector wholesalers to us because they rather sell through our existing agreements, because also these companies have quite a laborious due diligence process to vet their clients, and obviously they are familiar working through us. You are absolutely right that typically the private sector volumes are relatively small. So we actually see that some of the suppliers tell the customers, and we've been referred to by several suppliers to multiple private sector wholesalers, to say, why don't you use an international agency to transit this request, because that saves everyone a lot of time on setting up systems, doing due diligence and all that. So I think it's definitely an interesting model to think through as the private sector is eager to see how you can benefit from the existing donor negotiated prices with these suppliers.
Okay, yeah. And one could also have the thought that, I mean, accessibility is also about much more than what only passes through the public sector institutions. It is also, in many countries, extremely important what passes through the private pharmacy. So there I have sort of a question, actually. I could try to also ask that one to ask Prashant or that one. But if you have a product and it is at a low public sector price, it can be procured like that, but can the product pass at the same price out to private sector wholesale? No, sorry, not wholesale, but retail into the pharmacies. I mean, does there necessarily, is there a way to make the products, quality products, generics, available at private retail level? Because that would actually also very much improve the accessibility of these products in many countries, next to the existing system. So maybe Prashant or Enrique could have a comment on that, because you're selling every day to private retail.
Yes. Hi, yeah. Oh, sorry.
Yeah, go ahead, Prashant. Go ahead.
Okay, thanks. Yeah, so of course, most of Africa is generic in the supply chain. The supply of drugs is all from generic manufacturers. So Zimbabwe is unique in the sense that because we have we still have hyperinflation. There's arbitrage opportunities just in the currency itself, and people are always trying to cost at replacement, which is what, and nobody knows what the replacement value is of a US dollar in local currency. So currently we have a huge issue in Zimbabwe where prices of drugs out of pharmacies are totally overpriced, according to wholesalers, and according to the pharmacies, they think it's the wholesalers who are being unreasonable in their pricing. So this is what's happened now. But if I go back to the first formative years of dollarization in Zimbabwe between 2009 and 2015-16, up to 2016, there was stability in pricing. The pricing was not an issue because there was constant supply, there was availability, and there was competition amongst different wholesalers who managed to get a fair number of generics registered in Zimbabwe. So it was fine. There is a model to restrict retail pricing to a maximum of 50% in Zimbabwe, but really right now it doesn't work. Retail pharmaceutical margins are in the region of 100% plus. So, and that's really just a factor of the economy in this country. It makes it very, very difficult to try and get pricing out to a patient at what we think is a good value.
Okay, thank you, Prashant. Enrique, you also had a comment?
Yeah, I was saying that obviously it's a good idea to try to partner with some retail chains. This is true especially in English-speaking Africa, because retail chains don't exist per se in French-speaking Africa. It's also useful in the sense that if you take the example of Nigeria, pharmacists can actually import drugs without those same drugs being registered. They get a special exemption. So a partnership there could make a lot of sense, just to speed up also the importation process. As regards controlling the prices, the retail prices, I think there again, if you deal with the chain, it's easier, and since the volumes would be there for them, the value proposition would also make sense.
Okay.
Pierre, just to add, sorry, just a quick one, just to add to that. So in Zimbabwe, our preference is really to deal with the medical aid societies, because it's in their interest to make sure that the cost of drugs, or the distributive cost of drugs, is kept at a minimum to their patients or to their members. And increasingly, the medical aid societies in Zimbabwe are opening up their own chain of pharmacies to distribute the drugs to their members.
Okay. Okay. Yeah. So we are having a question from the audience. See. Yeah. Okay, this one is actually not specifically on procurement. Well, and I think we are, well, anyway, we could just let you answer the question. The question is, so what are the biggest challenges in SIM to distribute pharmaceuticals? That must be for Prashant.
Yes, yeah. So thanks for that. The biggest challenge is multitude. One is that the fact we have to have the forex in place. It's a difficult trading environment in Zimbabwe because of the forex challenges. That's one. The second one is, of course, just the time for registration for new molecules. It can take up to 2 years for a molecule to be registered in Zimbabwe. By that time, things would have changed in terms of trading or whatever, the treatment regime, anything that would have happened. So one is really, it's the financing of your product right now from Zimbabwe, and then the cost, the time for registration.
Okay, thank you. We also have a comment which says here, the challenge of managing quantity discounts vis-a-vis expiry should be sorted by contracting large volumes, but staggering the delivery. I guess that's a well-known solution which has also been tried for quite a while, but there's not necessarily flexibility in that. So that's one of the challenges of that option, but I guess it's a known possibility. We are approaching the end of the webinar, I can see. So Bethany, I think we should begin to round it off, I assume. Is that correct?
Yes, that sounds good. It's time for wrap up. You're right.
Okay. I would really like to thank all the participants, Joe, Prashant, Emeric, and Wesley. And I mean, of course, we know that this kind of a talk it's only a start. It's just bringing things to the table. There's no way to finish it in such a relative short time. But I think we did discuss some possibilities, and we also have both public and private people at the table, and there are ways to do these things. So I guess that could be something that comes out of it, say that there should be a way forward. But it also says something about that there are complexities and definitely not one size that fits all. So one must be careful when approaching it and adjusting to the realities on the ground and the realities of these companies, these people, various institutions, so they can actually go into it. That's about it. Bethany, will you finish it?
Sure thing. I just want to thank everybody so much for joining us today. All of our panelists, Per, thank you so much for moderating this really important and timely discussion. And as I said at the top, this recording will be made available on our website. And just want to thank everybody again so much, and have a great rest of your day, evening, and a very pleasant tomorrow. Take care.
Okay.
Bye.
Thank you very much, everybody.
Bye.
Thank you.
Thank you. Bye-bye.